Hello, nursing students. We're here to talk to you today about peptic ulcer disease. All right. So, what is peptic ulcer disease? When we think about it in a pathophysiological sense, it's a disruption of the mucosal integrity within the stomach or the intestinal lining. This will show a defective or an excavative look to it when examining the tissue lining. Now, this is caused by an active inflammation that is causing an erosive effect. So, when examining it through an endoscope, you would see breaks in the mucosal surface that could be up to 5 millimeters in size, and its depth can range from the submucosa or even down to the muscular layers of the lining. So, when considering the development of peptic ulcers, there's several agents that can cause its development. Things like acid, pepsin, bile acids, or pancreatic enzymes that linger within the mucosal tissue can result in its development. Other things like drugs, specifically nonsteroidal anti-inflammatories or aspirin, will have the same result. Another very common cause is from the H. pylori species of bacteria, which result in an infection of that area. So, when considering the anatomy behind peptic ulcer disease, you'll see that there are two main organs that are affected. The first is the stomach, and this is where we would see the development of gastric ulcers. Um, with its development, a common culprit is excessive use of nonsteroidal anti-inflammatories or aspirin. What's important to note is that these drugs will cause a inhibition of the mucus secretion, and this is detrimental since the mucus lining plays an important role of defending the stomach from damage from the acids it produces. So, with the impaired mucosal defense, it will lead to erosion of the stomach lining. There's two main regions within the stomach that are affected. The first is the body of the stomach, but more commonly you'll see the pre-pyloric area, or right before the pyloric sphincter, where these gastric ulcers will develop. The other organ that we see development of peptic ulcer disease is found within the small intestine, and this is where we would call it a duodenal ulcer. Uh, Primarily, the duodenal bulb region, which is near the pyloric sphincter, is most affected, and this is due in part that it's receiving the high acidic content of the stomach, and it lacks the bicarbonate secretions to address that. With that, we see that H. pylori infections will damage the mucosal barrier, and hence we see the development of duodenal ulcers. Okay, let's talk about some common causes of peptic ulcer disease. One of the most common is due to a bacterial infection from the H. pylori species. This is especially common within poor economic places, especially developing countries where there's unsanitary living conditions, unclean food and water, which can be a vector. Another vector can happen when a person has infectious gastric content and that comes in contact with another person. Uh, this really highlights the importance of cleaning your food because this can happen with fecal to oral transmission through contaminated food or water. The other main cause of peptic ulcer disease happens with excessive NSAID or aspirin use. With that, their mechanism of action prohibits the synthesis of prostaglandins, and with that, prostaglandin is not able to allow mucus secretions to happen, and with that, you will see the mucus lining damage. Another contributing factor to peptic ulcer disease involves genetics. Genetic mutations within the hepatic cytochrome P450 system will cause a delayed metabolism of nonsteroidal anti-inflammatories. So, with this decreased metabolism of these drugs, you'll see a elongated effect of decreased mucus production. And with that, you'll see the development of ulcers a lot quicker. Um, this is an important thing to assess in a client's medical history. Do they have first-degree relatives who have had a history of duodenal ulcers? Because this would increase the risk for them threefold. Great. Now, since we have an understanding behind the pathophysiology behind peptic ulcer disease, let's talk about some signs and symptoms. Strangely enough, 70% of PUD cases, the client will be asymptomatic prior to the onset of symptoms. When they do occur, it usually happens 2 to 3 hours after a meal. Clients will describe it as an intense, burning, gnawing sensation and is even strong enough to awaken a sleeping client. Other symptoms would be nausea or vomiting. Now, this is an important thing to note. If they do vomit, check for hematemesis because this would be indicative of a bleeding ulcer. So look for bright red or coffee ground color. Severe side effects and symptoms directly relate to the progression of the ulceration. So what really is happening is that this ulceration is causing perforations within the stomach or intestinal wall. When this occurs, the client will have sudden severe abdominal pain that will radiate to the back. Also, when inspecting the client, you would notice abdominal rigidity, pale skin, and cold sweat. This would be an important time to check for hematemesis. There are some important distinctions that could be made in terms of signs and symptoms in helping identify gastric or duodenal ulcers. Although the client will report the common epigastric pain, ill-defined aching, or hunger pain, gastric ulcers can be identified with onset of pain with food intake. While with duodenal ulcers, the onset of pain will occur 2 to 3 hours after the meal. Now, there's an important thing to note, and that's gastric ulcers risk increase with age, especially in the 6th decade of life. Also, males are more common to experience gastric ulcers.
Thank you, Eric. So peptic ulcer disease comes with a few complications, one of them being gastrointestinal bleeding. This is going to be our most common complication with PUD-related disorders. We're going to see this more often in our elderly clients than in our younger ones, but it can also happen with our younger clients as well. So for complications, a couple of more. These are a bit more serious, less common, but penetration of in an ulcer is horrible. It's tunneling from one organ to another. It can go into the pancreas, or it can turn left and get into the hepatic lobe. None of this is good, and it's probably going to require some sort of surgery if it doesn't, if it's not resolved through medication of some kind. Gastric outlet obstruction, also not a good thing. Let's just go out there. Not a good thing. We're going to see inflammation and edema with this sort of complication. How are we going to treat this disorder or disease? We're going to use antacids right off the bat. We're going to try to neutralize the acid within the stomach. Some of the adverse effects of this could be constipation, so you may need a stool softener if you're constantly pounding antacids. Just food for thought on that one. Getting right to it, H2 receptor antagonist, kind of think of it like parking an H2 Hummer on top of a receptor site. We're going to block or at least inhibit the secretions of acid in hopes that it's going to relieve some of those peptic ulcers, and we can get to healing, which we definitely want to do. All right, boys and girls, we've got more treatment for you with proton pump inhibitors. We're going to see this inhibit pretty much any potassium pump or hydrochloric acid pump. It's going to calm the stomach down a little bit and allow for any ulcers to possibly heal. Uh, this is also a good idea to take with the meal, just so it kind of works in conjunction and you can get a nice relaxing meal instead of having that burning sensation when you eat. All right, y'all, this treatment's going to coat a nice lining around the stomach in like a viscous paste. And that's just going to really help to protect the stomach from any adverse effects while eating, like just one more irritation for the stomach to avoid. The production of hydrochloric acid and things of that nature, just rocking it pretty steady. We're going to see that reduced, and because of the paste, it's going to protect with a barrier-like substance, and just really allow us to either heal and or absorb, take in the food and get it past the stomach lining into the intestine where it can be really absorbed. Last but not least in treatment is going to be surgical management. We're going to see elective surgery where we kind of know what we're going to be doing. There's a good plan ahead of us, and we're able to definitely plan out our meals, or like lack thereof meals, because you never want to eat right before surgery, especially when it's going to be a gastric surgery of this nature. Also, the less prepared version is emergent and or urgent. We're going to see that with like ruptures and tunneling, stuff like that. These are going to be probably through the ER, and you're not going to have much time or notice that you're going to be all of a sudden a surgical patient. So just best to keep with the treatments above and avoid surgical courses altogether, in my opinion. Stay away from the knife. Why don't we?
Okay, so now that we've reviewed peptic ulcer disease, we're going to do some NCLEX-style questions to test how well we understood the material. So the first question is: a patient has developed a duodenal ulcer. As the nurse, you know that which of the following plays a role in peptic ulcer formation? And this is a select all that apply question. So we have spicy foods, H. pylori, NSAIDs, and Zollinger-Ellison syndrome. And we didn't get to review that last one as much, but this is a disease in which tumors cause the stomach to produce too much acid, and this can be a factor in the formation of peptic ulcers. So take a few seconds and review the answers, and we'll review which one is correct. Okay, so when we look at the answers, we know based on the material that we learned that H. pylori and NSAIDs are some of the most common causes for peptic ulcer formation. However, Zollinger-Ellison syndrome can also be a factor, as the increased gastric acids can help with formation. Foods and stress can irritate ulcers or cause difficulty with their healing, but there actually is a lack of evidence that they are the sole cause of them, so spicy foods would not be correct in this situation. Now, our next question states, you're educating a group of patients at an outpatient clinic about peptic ulcer formation. Which statement is correct about how peptic ulcers form? So you have an increase in gastric acid is the sole cause of peptic ulcer formation. Peptic ulcers can form when acid penetrates unprotected stomach mucosa. This causes histamine to be released, which signals to the parietal cells to release more hydrochloric acid, which erodes the stomach lining further. Peptic ulcers form when acid penetrates unprotected stomach mucosa. This causes pepsin to be released, which signals to the parietal cells to release more pepsinogen, which erodes the stomach lining further. And the last one, the release of prostaglandins cause the stomach lining to break down, which allows ulcers to form. So again, take a few seconds to review the answers, and we'll go over which one is correct. Okay, so reviewing these answers here, B is going to be our correct one. Peptic ulcers can form when acid penetrates unprotected stomach mucosa. This causes histamine to be released, which signals to the parietal cells to release more hydrochloric acid, which erodes the stomach lining further. This is correct, as pepsin is not released from the parietal cells. It is histamine that is released, causing an increased production of the hydrochloric acid, which erodes the stomach lining. Peptic ulcers can be exacerbated by increase in gastric acid, though this is not the sole cause of their formation. Lastly, prostaglandins do not cause harm to the stomach lining. Rather, they actually protect it by causing stomach cells to release mucus that contains bicarbonate. This then controls acid amounts via the parietal cells and regulates perfusion to the stomach.
Thanks for watching.